Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. We're glad you joined us. Before we begin, I'd like to thank our sponsors, Aultman Health Systems. Today, Brad and I are broadcasting from our administrative offices, and our special guests are Dr. Sabrina Shilad, Dr. Evie Klenotic. I hope I'm pronouncing these names correctly. Please correct me, okay? And Dr. David Angari from the Aultman Breast Cancer Care. Good morning and welcome to the show, doctors.
Good morning.
We've never had three guests before. Okay.
Awesome.
Breast cancer is the most frequently diagnosed cancer in our community and nation. Aultman Breast Cancer is the first Stark County facility to earn the Center of Excellence designation from the American College of Radiology. We'd like to remind our listeners today our program will later be available on our podcast. Just look for Health Matters with the Medicine Center Pharmacy in your favorite podcast app, and please subscribe.
Again, good morning, Dr. Shilad. Tell us a little about yourself, please.
Oh, well, I guess I am the breast surgical oncologist at Aultman Hospital, and I have my new partner with me, Dr. Eve Klenotic. So I'm from Northeast Ohio. I grew up outside of Cleveland and then came to Canton after my general surgery training. I've been at Aultman since 2010, and I was doing general and trauma surgery for a few years, and then I slowly started transitioning to the land of breast. I think I moved into the breast center part-time around 2012, and then since then have just been focusing more and more on our breast cancer patients. Just as the needs of the community and the hospital increased, I sort of started devoting more time to that patient population. And then a few years ago, I transitioned to taking care of only our breast cancer patients, which has been nice to sort of focus on that group of women and men.
What is a fellowship trained breast surgeon?
So a fellowship trained breast surgeon is a surgeon who has done at least 1 or sometimes 2 extra years of training, focusing specifically on taking care of the women and men who develop breast cancer. And so the path to get there is usually at least 5 years of general surgery training or 4 years of OBGYN training, and then extra 1 to 2 years focusing just on breast.
So tell us the benefits of going into a breast center.
So one of the great things about coming to our breast center is that, so you're seeing people who are focused on people with breast problems. And so our breast imaging center is great because our radiologists there have also done extra training in breast care. And so it's very much, this is what we sort of do all day, every day. And so it's nice to sort of get that focused care on just the breast, which affects so many women. And so we try to make things as streamlined as possible. So when you come to the breast center, you get your mammogram, you get your ultrasound, you see a physician or a nurse practitioner. And so we try to make everything as seamless as possible and as smooth as possible for our patients.
Wow.
Dr. Klenotic, tell us about yourself.
Sure. So I actually trained at Akron General Cleveland Clinic in 2011 and has been practicing as a general surgeon after that in Willoughby area. And then last year I had the privilege of going back into like a breast surgical oncology fellowship at University of Arkansas just to learn more tricks and tips. And I can't be more thrilled to join Aultman this year. It's a fantastic team here.
What do you say to someone who tells you that they don't need to be checked because they don't have a family history of breast cancer?
That is an excellent question. The majority of breast cancer patients do not actually have family history, and only about 10% or so they would have family history, and about 5% has like the pathogenic genetic abnormality. So it's so important for women who doesn't have family history to still be cautious and to kind of keep up to date with their screenings.
Okay, so speaking of screenings, can you tell us when you should perform a self-exam and what should a person be looking for?
Great. It's good to do self-exam monthly, ideally in the mid-cycle. And the goal is to familiarize oneself with their own kind of tissue, and by doing the routine exam, so that if there is any changes, they would bring it to our attention for further evaluation.
Okay, so if you find a lump, what's the first thing you should do?
Stay calm, because most breast lumps are benign, such as cysts. However, it is very important to take it seriously and to see a healthcare provider for exam and further evaluation with imaging.
So, Dr. Angari, please tell us a little bit about yourself.
Sure. So I'm a radiologist. I'm the lead mammographer at Aultman. I was born and raised in Canton, Ohio. I did all of my training at Aultman. And like Dr. Shilad and Klenotic, I have subspecialized training that's specific in breast imaging and the diagnostic aspect of breast cancer. Everyone kind of thinks radiologists, we perform mammograms, but we don't. We really just kind of sit in the background. So you won't really see us. We're really behind the scenes for the most part. The only time you would ever really meet me is if you ever need a breast biopsy done.
So what age should mammograms begin, and how often should a patient have them done?
So there's multiple organizations out there that have different recommendations for when people should start their screening and how frequently they should do their screening. In the Breast Care Center, we follow the National Comprehensive Cancer Network recommendations and the American College of Radiology, which basically says for average risk patients, screening mammography should start at the age of 40, and it should be performed every year.
So who should get a mammogram earlier than 40?
So generally speaking, there are two scenarios in which patients should start their screening earlier than 40 years old. So the first one being if a patient has a first degree relative with cancer, so a patient or a sibling, then screening should begin 10 years before the age of onset of that first degree relative. So for instance, if you have a mother who was diagnosed with breast cancer at age 45, then you should begin your screening at age 35. The second scenario would be, if a patient has a history of chest radiation at a younger age, so, specifically between the ages of 10 to 30, then they should begin screening 8 years after that treatment, but not before the age of 25. And generally screening before the age of 30, we say to do with an MRI. And if you're over the age of 30, we'll do mammograms plus or minus MRI.
Dr. Shilad, it's vaccine season. Does getting a vaccine affect your mammogram or cause any changes to the breast?
I'm actually going to punt this question over to Dr. Angari. If you don't mind.
Absolutely.
Okay.
Absolutely. So as far as vaccines are concerned, so back when the COVID vaccine first came out, there was a lot of concern that the COVID vaccine was creating what's called lymphadenopathy, or swollen lymph nodes in your armpits that we can see on mammograms. And that was causing a lot of extra workup for patients. Since that happened, there was recommendations to wait after your COVID vaccine to kind of delay doing your mammogram. But since then, we have had new studies that have showed that it really doesn't benefit patients to wait. So we actually do allow patients to do it. We just ask for people to tell us that it's been that they've had a vaccine.
Okay. So, in the pharmacy, we get a lot of questions from patients, and many times patients are concerned about x-rays, dental x-rays, walking through the scanners at the airport. What can you tell us about women who are fearful of getting a mammogram because they don't want to be exposed to that level of radiation?
Yeah, I think that's a great question. I usually try to put radiation into perspective for patients so they can understand it, because it does sound scary. First, I'll say the amount of radiation that we use for imaging purposes all across the board is regulated, and all of the equipment must be periodically certified by a medical physicist to ensure, adequate quality and dose regulations. And secondly, I'll say that the amount of radiation for a typical mammogram is incredibly small. For perspective, every day we're exposed to background radiation just from our natural surroundings, mostly from the ground, but also from the sun. And over the course of a year, we'll be exposed to 3 millisieverts. Millisieverts is the unit for measuring radiation. So we'll be exposed to 3 units of background radiation per year. A mammogram has an average effective dose of approximately 0.3 to 0.4 millisieverts. So again, really small doses that we're using. Some other common imaging that we do, even like a CT of the abdomen or pelvis, which is one of the higher ones, is around that 15 millisievert mark. So even within the imaging realm, we're using a lot less radiation for mammograms. And then finally, I always tell people that the benefits really do outweigh the risks. Approximately 1 in 8 women will develop breast cancer in their lifetime. And women screened regularly for breast cancer have a 47% lower risk of dying from the disease within 20 years of diagnosis than those who are not regularly screened. So, for me, it just, the risks or the benefits really do outweigh the risks in this scenario.
Wow. Okay, doctors, it's time for our first break, if you believe it. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Friends, just a reminder, just stop by the pharmacy and talk to a pharmacist about your Health Matters drug savings program. We want to help you stay well and save money.
Okay, so we've been talking about mammograms, and I guess, I've been, with my wife when she's been waiting on the results. Can you talk to what it means if a mammogram finds something? Because it can be a stressful time for a person.
Absolutely. I think that's a really important question, because when a mammogram finds something and it asks for a patient to come back for any additional imaging, it can be scary. It can be nerve-wracking. And naturally thoughts start running through our heads of, oh my goodness, I have cancer. But the first thing I'll say, just to kind of reiterate what Dr. Klenotic said, was just remain calm, because that's not really what it means. Mammograms, they do a pretty good job of detecting abnormalities, but they don't always characterize those abnormalities pretty well. So I'll use a little bit of a metaphor to illustrate it. If you can imagine yourself walking down the street in the evening and you see a shadowy figure in the distance, you start worrying to yourself that, maybe it's a person there, or maybe it's an animal, or in the spirit of Halloween, maybe it's a monster or it's a ghost. So you go to your tools to figure it out, and you pull out your phone, turn on a flashlight, and you're able to see it's just a fire hydrant. So that's the same thing with mammograms. The finding may be benign, it may be cancer. So we use our additional tools to try to figure it out, which may mean doing additional, different mammographic views, an ultrasound, an MRI, or ultimately maybe we need to do tissue sampling of it with a biopsy. Now, I always like to use statistics to better understand and put information into perspective. So for every 1,000 screening mammograms, approximately 100 patients, or 10% of the cases, will be recalled for an abnormal finding. And if it's a first time ever mammogram, that number can actually be as high as 20%. And of those 100 patients, approximately 10 to 20 patients will need a biopsy. So that's another 10 to 20%. And then of those 10 to 20 patients, somewhere between 3 and 10 patients will be diagnosed with breast cancer. So really, we're only talking about 3 to 10% of patients who have abnormalities on their mammogram will ultimately have a cancer diagnosis. So I think those numbers should offer a little bit of comfort and reassurance to ease the fears and help a little bit, preventing patients from automatically assuming that they have breast cancer just because a mammogram found something.
Wow. So Dr. Klenotic, who should have a high risk screening? What does that mean?
Great question. So high risk screening means being screened sometimes less than 40 years old. And the screening by exam and imaging would be more often than yearly. So we would do yearly mammogram and yearly MRI. So every 6 months they get some sort of imaging. And this women has more than 20% lifetime risk for invasive breast cancer based on different factors, including but not limited to family history, breast density, previous biopsy, radiation, and their gynecologic history.
So what does the Tyrer-Cuzick score on a mammogram report mean? Did I say that right?
Yeah, Tyrer-Cuzick.
Yes.
The Tyrer-Cuzick score, or TC score for short, it's a model for assessing breast cancer risk. There are a few different models out there, but the TC model is one of the more widely accepted models and the one that we use at our breast care center. And it takes into account a lot of the different risk factors that Dr. Klenotic was just speaking of. And it generates for you a 10-year risk and a lifetime risk for developing breast cancer. And then it stratifies those risks between average risk and high risk women. So generally, like Dr. Klenotic was saying, anyone with a lifetime risk that's greater than 20% would be considered high risk.
So who should consider genetic testing, and what does that tell us?
Individuals with strong family history, especially breast, prostate, ovarian cancer, and pancreatic cancer, should have genetic testing. And any cancer patients, we would offer genetic testing as well. In the setting of cancer, the genetic testing will tell us if there is any pathogenic mutation that would be responsible for the breast cancer. It would also tell us if they're predisposed to different kind of cancer so that their family can also be tested and they all can be screened sooner.
Okay, Dr. Angari, can you give me another acronym explanation? This one is, what is MTDB?
I'm actually going to punt that one over to my surgeon colleagues.
Okay, sounds good.
This is usually how we work. I punt to him, he punts to me. It's
Well, it's a team, right?
exactly.
It is a team.
Yeah.
It's an example.
Yeah. So MTDB is our multidisciplinary tumor board. And so one of the things that we do, so when we talk about any of our breast cancer patients, you know, most breast cancer patients, things are sort of, I guess, as expected. But sometimes some of our breast cancer patients are just, it's a little bit more complicated what's going on based on either what their imaging looks like, what their biopsies show, family history. And so some of those things can make their care a little bit more complicated. And so a lot of times what we like to do is talk about these patients in a sort of a group setting. And so it's a conference that we have weekly, and it has both surgeons and medical oncologists, and our pathologists are there, our radiologists are there, our radiation doctors are there, as well as our team of navigators and our clinical trials individuals. And so we all talk about our patients together to sort of get as many sort of different brains working on this to sort of help make sure that patients get the best sort of personalized care for each person. And so again, so we do this weekly, and it's a great way to help get us all on the same table, make sure that we're all talking about the same thing. And it's extra sets of eyes looking at things. I mean, because sometimes, you know, the way I'm going to look at something is going to be different from the way Dr. Klenotic looks at something. And so this way we're looking at those patients together, and she might say, hey, what about this? Or I might say, hey, what about this? And it's a nice way to sort of really collaborate and work together, making sure that our patients get the most comprehensive care that we can deliver to them.
And this is one of the benefits of a breast center.
Okay, so should you receive additional screening if you have dense breast tissue?
So most institutions are already performing tomosynthesis, which is also known as 3D mammograms routinely for their screening mammograms. And I would say that that's really the most agreed upon additional quote unquote screening for dense breast tissue. If you're getting your mammograms at an institution that doesn't automatically do that, then I would say I would definitely recommend requesting it. But aside from that, there's no general consensus on the need for additional screening just because of dense breast tissue. But supplemental screening options do exist, which include MRI and ultrasound, or specifically automated breast ultrasound, which is a relatively newer technology that not all centers utilize, and we don't currently use that at Aultman, but we do offer MRIs.
Just a clarifying question for benefit. I had a patient in the pharmacy last week who had said that they were being evaluated at a different level because they had fibrocystic breast tissue. Is that the same thing as dense breast tissue, or is that something separate?
That's something different. Fibrocystic tissue is technically a pathologic disease, which is very common and almost on the spectrum of normal, but it is not a precursor for cancer. It's not a reason to increase screening.
Okay. So is there a point in time when women should stop getting routine breast exams?
Yeah, and so different organizations have, again, different recommendations on that. But again, from the standpoint of, the societies that I adhere to, being the American College of Radiology and the National Comprehensive Cancer Network, really there is no age limit for a mammogram. I do think it requires a conversation with your doctor. I think that there are some scenarios that maybe it would be reasonable to stop performing mammograms, like maybe a limited life expectancy, or a patient knows that they wouldn't pursue treatment if breast cancer is found. I think those are reasonable, times to say, okay, we don't need to do this anymore.
Dr. Shilad, once diagnosed with breast cancer, what is the best next step?
I'd say take a big deep breath and be like, okay, I got this, and we're going to come up with a plan. You want to see someone who is comfortable taking care of breast cancer patients. And so a lot of times the first stop is usually a surgeon. And so the surgeon, the medical oncologist work very closely in the first part of it. So a lot of times when you meet with a surgeon, they're going to talk to you about your pathology, your sort of the tumor types, all the different things that go into what makes your or each individual's breast cancer unique. So there's so many different things that come into play when it comes to a woman and their breast cancer. So it's the type of breast cancer they have, whether it's ductal or lobular, and then all the different factors that go into it. Does it respond to hormones? Is it biologically more aggressive? And so all those things come into play. And so your first stop is meeting with someone to then talk about, what does this diagnosis mean? Fortunately, breast cancer treatment has come a long, long way. And most of our treatment, or most of our patients, do excellent long-term with treatment because the treatment has improved so much.
Wow. Okay, doctors, at the bottom of the hour and time for the news. Thanks for joining us this morning on Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters at the Medicine Center Pharmacy. I'm your host and pharmacist, Paul White. This morning we are talking with the doctors of the Aultman Breast Care Center. What are the common surgical options for breast cancer, and if one provides a better long-term outcome than others?
So the two main options that we talk about surgically is a lumpectomy or partial mastectomy, which is where we remove part of the breast. And the other main surgical option is a mastectomy, where we remove the overwhelming majority of all the breast tissue. Now, with a partial mastectomy or a lumpectomy, usually radiation is recommended. And the reason we want to do radiation after a partial mastectomy or a lumpectomy is, one way or the other, we want to treat the whole breast. And so with both options, you're treating the whole breast. It's just with a lumpectomy, you're removing part of the breast and you're treating the rest with radiation. And with a mastectomy, you're surgically removing the entirety of breast, or the overwhelming majority of all the breast tissue. Now, within those we have different sort of subcategories. Now, traditionally, we do a lumpectomy, but one of the new techniques we do with our plastic surgeon colleagues is we can do an oncoplastic reduction lumpectomy, which is where we still remove part of the breast, but this is for our bigger breasted women who sort of are interested or are good candidates for a reduction. And so we do a reduction at the same time, decreasing most of the volume of the breast, so they end up with a smaller breast. Now, with a mastectomy, usually there's no radiation, but sometimes there is. But also with a mastectomy, women have the option to do reconstruction. Now, sometimes we do implant-based reconstruction, where it's either a silicone or a saline implant. Sometimes we can use their own fatty tissue. Sometimes we're able to preserve all of their breast skin, including the nipple and areola, and do what we call a nipple-sparing mastectomy. Sometimes women don't want any of that, and they say, hey, just make me as flat as you can make me, which is also a fair option. Long-term outcome and survival is actually the same between the both. options, the lumpectomy and the mastectomy. And the reason that they're the same and we offer them as equal is that in both situations, we're treating the whole breast. It's just different ways of treating it.
Interesting. How do these outpatient surgeries help the patient heal faster? And what is it like for a patient in the following days and weeks?
Well, so traditionally when we do lumpectomies or oncoplastic reduction lumpectomies, those women do go home same day. And there's usually not too much pain or discomfort with them. A lot of times our patients, we are checking their lymph nodes, and it's when we check their lymph nodes, that's usually the part that's the most uncomfortable after surgery. And so the recovery, I tell women, is usually pretty good with both options. With a mastectomy, historically, women used to spend the night afterwards. But actually a few years ago with COVID, when beds started getting tight, we started sending women home same day and they loved it. So now frequently we just give women the option. If you want to go home after your mastectomy, even if you have reconstruction and you're comfortable, your pain's controlled, you're doing well, and you feel comfortable going home, we let you go home. If that idea makes you uncomfortable and you'd rather spend the night, then we're happy to do that as well. Now, as far as what things are like, I mean, women, especially with a mastectomy and reconstruction, they're going to be sore the next few days. But again, I tell women, within a few days, you're going to be doing most of what you were doing beforehand. We tell women a lot of times, just use some common sense, take it easy. If you're doing something and it hurts, then back off and try again in a few days. Now, I will say that our plastic surgeon colleagues, they have many more restrictions on what they tell our patients as far as reaching fully and doing things like that, just from a reconstruction standpoint. But generally, most women, they don't have too many restrictions. And then we do go over sort of the things that life we expect to be like the next few days.
I think we already dealt with this, or you already answered this question. But do women with breast cancer always need radiation?
No, so they definitely don't always need radiation. And so with a lumpectomy, traditionally radiation is recommended, but the newer data and literature in radiation oncology is showing that some women, they don't always need radiation, even with a lumpectomy. And so we encourage our patients to go meet with the radiation oncologist and see if radiation can be omitted. Now with a mastectomy, there's usually no radiation, but sometimes those women do need radiation. So there's always, I guess, that chance with a mastectomy that you might still need radiation.
Is when radiation is needed, is there only a certain level that radiation you can give a patient, or does it vary?
So
and I'm talking about the strength, I guess.
Yep.
Okay.
Yeah, I think I understand what you're saying. So what our radiation oncologists do is they're sort of very aware of how much radiation has gone to a specific part of their body. So if someone's had radiation to the right breast, they can still have radiation to the left breast. When it comes to doing radiation again to the same breast, then that makes life a little bit more sort of tricky and complicated. And so our radiation doctors really at that point have to look at how much radiation specifically did they get, how long ago was it, how is the skin and the tissue that was radiated before, how is it now? And so historically, we always used to say, like, once you have radiation, you can't have radiation again. And there's data showing that you can have radiation, but it's very much a person to person, very specific situation. I hope that's not too vague for you. I'm sorry.
No, I understand. I had parents, okay, they've been gone a long time, who both had mouth cancer, lung cancer, of course they were both smokers, and I believe back then, which was a long time ago, that the radiation was a little bit less managed, if you know what I mean. I'm not blaming anybody. It's just the quality of the radiation equipment, I guess, is far superior now than it was 40 years ago or 50 years ago.
Absolutely. Yeah. The technology has changed so much in the land of radiation oncology that it's very pinpoint focused treatment now.
Okay.
Okay, Dr. Klenotic, what should you do if a provider says you are too young for it to be breast cancer?
Unfortunately, we do see young women with breast cancer. And while it is rare, it is the most common cancer among women ages 15 to 39. For me personally, the youngest one I've seen a few months ago was 21-year-old. I've heard a friend who's had a patient who was 13 years old. So it's very rare, but it's there. So it's very, very important to not ignore any symptoms. And it's better to just, for peace of mind, to just get the exam, see a provider, get the imaging to kind of, for peace of mind, get the reassurance that it's not concerning.
All right, a follow-up question to that, because you made me think of something. So would the symptoms you're referring to in a 21-year-old patient, would that be maybe doing a self-exam and feeling something that isn't right? Or is there something else? Because clearly that patient's not going to be having a regular mammogram, correct?
Correct. It would just be something that they notice while they shower, or if there is skin changes. A lot of times redness and warmth and kind of skin lesions can just be an infection, or it can just be a cyst, superficial cyst. But if it doesn't go away, it could be a sign of in situ cancer, such as Paget's disease, or if they feel lump, then it should be checked out to make sure it's not concerning for cancer.
Okay. Before our last break, can we talk about men, and do men need to be concerned about breast cancer?
Just like everything in life, we shouldn't live in fear. However, about 1 in 100 breast cancer diagnosis is in men. So similarly to the young women, if men notice any changes in the appearance of the breast, whether it gets bigger, smaller, feels a lump, skin changes, that they shouldn't ignore it just because they're not a woman.
Interesting. Okay, our final breaks here. You're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. Pharmacist Brad White, and I thank you for joining us. Let's get back to the last segment of the show. So, Dr. Angari, what factors increase the risk of developing breast cancer? And I'm going to guess smoking and some other things that
Sure.
are common for other,
Yeah.
types of cancer. But anyway, I'm sorry. Go ahead.
Sure. Surprisingly, smoking is not actually technically one of the risk factors, but
Kidding.
the most, this goes without saying, but the most obvious risk factor is just being a woman. It's the biggest risk factor. But aside from that, the risk factors really are going to be age. The older you get, the more likely you are to develop breast cancer, obesity, family history of breast cancer, or even a family history of ovarian cancer. If they've ever had a benign lesion that's been biopsied, some of those benign lesions do portray a increased risk, such as atypia or ductal hyperplasia. So some benign things do have an increased risk. Hormone replacement therapy, patients who have early onset of menses or go into menopause at a late age. Women who don't ever have children in their life or do decide to have children later in life increase the risk. Prior history of radiation treatment to the chest, and then Ashkenazi Jewish inheritance. Those are really the risk factors that are known that we discuss.
surprised that smoking isn't really a big player there, because it is for everything else. Lung, mouth, all that kind of stuff. So anyway, so what can we do to reduce the risk of breast cancer?
So one of the things that we encourage our patients to do is, as Dr. Angari mentioned, so the opposite of obesity, so trying to maintain a healthy weight. The other thing that's interesting is exercise. So actually exercising on a regular basis, good cardiovascular exercise actually lowers the risk of developing breast cancer. And we also encourage both our breast cancer patients as well as people who have not yet been diagnosed is good, healthy eating. And so it's sort of limiting your red meats and trying to eat more healthy fruit and vegetables. And, legumes, lentils, things in that Mediterranean diet. And so those are some of the things. Limiting alcohol consumption. And so I once went to a conference where they said that women should try to consume no more than 3 alcoholic drinks per week. And they said that you can either have them all 3 at one setting or spread out over the course of the week, but limit it to 3 a week. And so I think those are just some of the top ones that come to mind of things to do to reduce that risk.
And the smoking thing, I think it's not found yet. I think smoking in general, it's a carcinogen. So
it is overwhelming, the number of people that are still smoking.
Yeah.
I can't get over it. I mean, we have a lot of parking lots, okay? And guess what's all over the parking lots, okay?
Yeah.
So, just amazing, because we know what smoking does.
Yeah.
And it's just nuts. So anyway.
I'll also add to the smoking statement is that, and the surgeons can, verify this, but if you do end up being diagnosed with breast cancer and you have a history of smoking, your healing is actually going to be worse.
Yeah, I was just about to say that. Thank you.
Yep.
Okay.
Yeah, and so it's one of the things that when we're looking at reconstructive options for our patients who are interested in mastectomy, is that sometimes our plastic surgeons won't offer reconstruction to women who smoke just because they're at such high risk of wound healing complications. So it's definitely a huge factor.
I find it amusing when I'm backed up behind a car with a traffic light, and all of a sudden a huge cloud comes out of the window on the driver's side. Well, it's not cigarettes, it's the other stuff, and it just looks like the car's on fire.
Yeah.
That's so crazy. But anyway, so Dr. Shilad, please tell us where Aultman Breast Cancer Center is located and how patients can get in touch.
So the Aultman Breast Center is, that's actually a tough one. I mean, you go in the front doors. So it's wow. So it's the newer building. I guess so we have our new cancer center, and then sort of around the corner is sort of the entrance to the labor and delivery and the heart center. And so up those little steps, there's our breast center is right there. There's a cafe right outside, or you can go in the main 6th and 7th Street entrances, and it's right next to the gift shop. So what's interesting about the Aultman Breast Center is that, so the Aultman Breast Center is actually an imaging center. It's where Dr. Angari and his team live. Dr. Klenotic and I are sort of within that, but we are sort of separate, but have our own little corner in the breast center. So the way to contact the breast center, if you mammogram, imaging, any kind of radiology needs, so they have their own number. And then if you need to contact Dr. Klenotic and I or our office, then we have our own number as well. So we're actually 2 separate sort of entities in the same space. Now, certainly if you call the wrong number by accident, we have such amazing staff down there. They're always sort of transferring a phone call and getting someone to where they need to go. But we are actually two separate sort of entities encompassing the same space.
Okay. Dr. Klenotic, anything you'd like to leave our listeners with before we wrap up today?
Sure. Thank you so much for listening today. It is an important topic, and breast awareness is still very valuable. And of course, screening mammogram saves life. And I'm sure Dr. Angari agrees with that. And We have an awesome, wonderful, caring staff here at Aultman Breast Center, both in the surgery and radiology and all the multidisciplinary tumor board staff. And shout out to our staff nurses today who has birthdays, Kylie and Amanda. So, and we appreciate all of you. And please know that we are a resource to you all listener out there. If you have any questions, concern, don't hesitate.
Good.
Okay. Any final words from you, Dr. Angari?
Yeah, I think Aultman's Breast Care Center is simply, it's just a place where everyone from our techs to physicians to office staff to our hospital leadership, we really work as a team and take great pride in providing excellent care to our patients, regardless of religion, race, gender, anything. Anyone is welcome. And if I could take just one moment to go on a little brief soapbox for our department, breast imaging is incredibly, incredibly dependent on assessing for small, subtle changes from year to year, and also having the ability to correlate those findings between different modalities. So an ultrasound to a mammogram to an MRI. So for anyone coming to us who have imaging from outside institutions, we would, we love to see you, we love to take care of you. But in order for us to give you the best, most thorough and timely care, it really helps to have those prior images available at the time of your appointment.
Wow.
Little soapbox, but
Very interesting. Well, this is our 13th year for Health Matters on WHBC, and this is the first time we've had 3 guests at one program. We thank you very much. Okay. So thank you to our guests, Dr. Shilad, Dr. Klenotic, and Dr. Angari, and I am sorry about pronunciation, with Aultman Breast Cancer. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Aultman Health Systems and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy week, and we'll see you again next Friday and right here on News Talk 1480 WHBC. Thank you very much, doctors. It was very
Thank you.
interesting.
Thank you. Have a great weekend.
And you too. It's going to rain.
God.
That's not good, but
Yeah.
a little
Thanks. Have
better
a
next
good
time.
day.
Thanks
Take
for
care.
taking care of all of
care.
us.
Bye-bye.
Appreciate it.
Yeah. Have a good day.
you too.